So I thought I would just run through the transplant process with you, what actually happens when the patients go, goodbye, I'm going to Westmead. I don't know if anyone remembers this show called Gladiators. It was in the 90s. Um, Essentially, it was like these fit challenges would challenge these gladiators to do really, different sort of obstacles, like climbing a pyramid, and the gladiators would be on top trying to push them down, or they'd have like a ring thing where, like it'd be like monkey bars, and the challenge would try to get from one side to the other, and then they would have the gladiators trying to bring them down. And so that's kind of what transplant is really like. Um, a patient has to get to not only the acute phase of it, but also cross the chronic phase of things. The acute side of things I've represented with HAMR, so that's the perioperative phase. So it's things going into theatre, like the anaesthetic risks that might happen, the fluid shifts that might happen as they're pumped full of fluid, and the medication side effects. They tend to present relatively early on. The post-operative phase, which is kind of, when they come back to orange and we're managing the long-term things, which are things like cardiovascular risks, which is new onset diabetes after transplant, obesity, hypertension because of tacrolimus or their CNI that they're on. The bone health becomes a big thing. Not only, we discussed CKD MBD the last time, but on top of that, after getting a transplant, they're on steroids, right, which whittles away their bone, especially in the first in the first year. Of course, we have to think about rejection every time that they come in if they've got a rise in their creatinine, funny infections that they might have. We've got a patient upstairs at the moment who's a transplant who's got really bad C. diff colitis, for instance. Cancers, you would see a lot of people who've got squamous cell cancers. You might know one of your patients here who's recently transitioned on hemodialysis. Her skin is very chapped and she's had a few cancers cut out. And one of the big things in any of our patients is adherence. We've got patients here who have failed transplants or who have recently passed away. One of their bits along the journey is that they haven't done so well in terms of managing their medications. So I thought I would just run through a patient. So this patient is this one here. So at the time she was she one of yours? Yeah? Yes. Okay. So she, at this stage of acute transplant number 2, she was a 37-year-old law clerk who had a background of lupus nephritis. She got transplanted in 2011, however, unfortunately due to rejection, she lost that graft. So this is now 7 years down the line from that first transplant, 2018. So in the perioperative phase by HAMR, at 3 a.m. on a Sunday, the theatre was booked, so presumably around that time the patient was woken up from her bed in wherever she lives. So she had to travel from Western New South Wales over to Westmead Hospital. And that's, at this time, it's no guarantee that the transplant will actually go ahead or not, because it depends on the donor extraction factors. Luckily, by 12 p.m, everything is yes, we're all set to go. The transplant has arrived from wherever it's come from. It's sitting in Westmead. It looks fine. Let's go. So then at that stage, she gets the induction immunosuppression. So in her case, it was this thing called ATG, which is anti-thymoglobulin, which is actually a rabbit antibody which ablates all your immune system. After she got the immunosuppression, she went into the transplant at 2 p.m. Now the transplant probably takes about 3 hours or so for a standard kidney transplant if all goes well. Maybe about 4 hours if it's like a pancreas and kidney. And then so by 5 p.m. she was back on the ward. So when they come back on the ward, although it's on the ward in Westmead, it's actually more like an HDU ICU kind of setting. So it's a one-to-one nurse, and they've got their own room. So the recover takes place on the ward. Yeah, exactly right. So when they come in, they're pretty much all zonked down. They've got a CVC in, they've got an IDC in, they've got a million cannulas or whatever taking place. And so what happens is at the 0 hour mark, they come screaming through. You get the handover from, the anaesthetics from the surgeons, how much blood they've lost, any issues during it, was there any big bleeding or, any sort of drain sites that happens. You take x-rays, making sure that the line is in its right place. You usually give them a bit of fluid as well. And then you do an ultrasound to see if the vascularity of the kidney transplant is actually good or not. Okay. So she started to make urine pretty much immediately, about 20 to 30 mils per hour. So that was fine, but then sometime in that night she got a met call because her heart rate was 135 and she was febrile. Now, because she had a past history of ESBL, they pretty much just upscaled straight to meropenem at that stage, okay? And so this is just day 0. So you can see it's a big, long day from the patient, woken up at 3, and then who knows what. They're pretty much awake.
Attention staff, stroke call emergency department. Stroke call emergency department, thank you.
They're pretty much awake for 24, 48 hours. So day 1, she had lots of diarrhea, and that was presumed to be due to the mycophenolate, which is one of its big side effects. So she was changed over to myfortic, which is similar but different. Her creatinine didn't really change, though. It was still stuck at 565. So there was a question how she was actually going to go, but they said, look, let's plod on. Day 2, they pumped her full of fluids, both in the theatre, and just to try to get that kidney working. And so now she is 7 kilos above her target weight. So, you know, we've got patients here where like, they're like 5 kilos above. But this is 7 kilos over and actually going higher because we're trying to push high. At that time, probably not. Yeah. Okay, so they pushed on. Day 3, hemoglobin now down to 67. So now you've got not only a fluid overloaded patient, but they're also drastically anemic. So you can see there's a lot of physiological pressures on that patient. In addition, they said, I don't know, this kidney really isn't working, the creatinine is still stuck at 500. Let's just pulse with methylprednisone and see how we go. So one of the side effects of methylpred is that obesity, yep, but also in the short term, it ramps you up, makes you hungry, you can't go to sleep. So you get 3 days of that in a row. Okay. Day 4, they did another ultrasound to say, hey, look, so is this kidney going to work or not? There wasn't much blood kind of flowing into the kidney, and again, that's keeping with rejection, which is why they kept on with the methylpred. So she ended up on dialysis on day 6 to take off some of the fluid. Okay, so in that case, you call that delayed graft function because, you know, it just hasn't picked up. Day 7, she finally got a biopsy, and luckily it was just acute tubular necrosis because the kidney that she got was from an older donor, called an extended criteria donor, which is for people who are generally hard to match, bearing in mind that this was her second transplant, so she was probably sensitized. Yep. So usually at about the day 5 mark, people get discharged or their lines come out, IDC comes out, they're usually mobilizing and they can walk out, and then it's a daily follow-up at Westmead. Because of all this though, she kind of delayed a little bit, so it was only on day 9 that she discharged. Now one thing I do want to say is that what is standard about this patient is she was discharged on 37 separate doses of medications, right? Because you've got a whole heap of immunosuppressants, you've got your antivirals, you've got your nil stats going on, and it's a lot of stuff. Plus the pre-existing things on top. So 37 different doses in a day. Okay. So you kind of have to think about who are the people who we're transplanting. This is the whole. From the chronic care side of things, so now we're in the Vulcan kind of stage. So after her first transplant in 2011, 1 year afterwards, she got cryptosporidium. Then 2 years after her transplant, she got osteoporosis from all the dialysis days and from, you know, the prednisone that she's on. 3 years after her transplant, she got confirmed diabetes. 8 years on from her first transplant, she got another weird infection. And then so I've just started to become involved now, which is 10 years after her first transplant. And the things that we're working on is, first of all, her weight. One of the big issues I'm facing at the moment is her weight is really high.
Yeah, it is, and that is really high. And she's not a tall person either. So 5 litres to her, 7 litres is a lot of fluid.
Yeah. There was a question if she had cancer because she had a breast lump. So luckily that was all clear, but we were super paranoid, got some mammograms, got an ultrasound, got the surgeons to go do a biopsy of it, which she had to put up with. And then finally just 2 weeks ago, she got some rejection. So creatinine went from 200 up to 500 actually, and then after some methylpred pulses, it's come down. So we chose not to biopsy her because she has had a lot of immunosuppression already. There's not much really to salvage. So anyway, you can see from both the acute and also the chronic side of things, which has lasted 10 years, that there's a lot to do for patients. It's a lot of burden. So we need to choose the patients correctly. So throughout today, maybe just think about the patients that you have with the question of, are these transplantable patients or are they not? So there's not a lot of active contraindications for transplant. I mean, they're relatively straightforward. So if they've got an active infection, then clearly you're not going to transplant them. As you know, we've got this gentleman at the moment who's just had a BKA. So that was one of the barriers for his transplant, right? Because you're like, well, can we transplant him? Because we don't actually know if his foot's infected or not. If they've got a raging malignancy, then it's not a good idea, of course, because one of the things about immunosuppression is it stops your normal immune system from kicking out the bad cells. There are some exceptions, of course. Of course, people who use drugs, including smoking, you're not going to transplant them, and psychosis. Reason for that being not only because of the adherence side of things, but because the prednisone will make it worse. Inadherence we had a chat about, and also if there's anatomical issues. So say, because what they do is they plug the kidney onto the iliac arteries, so if you've got a lot of peripheral vascular disease and it's all just calcified, then you can't stitch it on because the blood flow won't go up there. Okay. So relative contraindications, I've kind of grouped it just into all these organ systems, and so you can see 1, 2, 3, 4, 5, 6, 7, 10 different things, okay, that patients have to pass in order to get on the transplant list. So let's just start off with the, what's that? So let's just start off with the brain first. One question is, can my forgetful patient get a transplant? And I guess it centers around adherence, right? We know that those who actually admit that they're not adherent to their therapy are actually about 5 times more likely to miss their medications when they get their transplant. And we know that inadherence to their medications causes about 15% of graft failure. But if a forgetful patient gets a transplant, is it possible? I don't know. It probably kind of is. You might remember this patient here.
Yes.
Her memory wasn't great, and of course there were some language barriers as well. But her husband is very good at keeping her on track, and so she's now been transplanted for maybe 2 or 3 years or something like that. And she's doing well, and that's one of the issues, isn't it? Yeah. Okay. If you've had a stroke, of course, same surgical rules apply. No transplants for 6 months. If you've had a TIA, 3 months after that. One thing to look out for is cerebral aneurysms. In our PKD patients, that's one of their things. So you just do a CT angio before to make sure that they don't have it. If they do, think about clipping it. What if they have cardiac issues? Clearly, as we've just discussed, it's a big cause of mortality in our patients. So the question is, do we screen everyone? I guess if they've got cardiovascular risk factors, then sure. If they don't, then maybe not. So say if you've got someone who's young, then you might just skip over it just because they're young. But if they're diabetic, if they've got a smoking history, if they've been on dialysis for over 2 years, or if they're like middle age or over, then you'll probably just screen through. So the screening tests involve like a MIBI scan or an echocardiogram. Their LV function has to be above 30% in order for them to transplant, because as we've seen from the first case, you're pushing them with a whole heap of fluids. Do they need to stop smoking? Yes.
You don't do nicotine levels? used to in Newcastle.
I've never, I haven't seen it done.
Yeah, we used to do it in Newcastle.
But yeah, right. So you could do a cotinine level to check that. Where did you check it at? Really? Okay. So you wouldn't believe the patient,
They would just do it routinely.
and would you tell the patient that we will check through?
They would be checked,
Okay. All right.
especially if they had been a smoker.
Yeah, right. Low level of trust, huh? Yeah, right. They didn't at
Very low level.
P8. Yeah, I haven't seen a test done at Westmead. I guess the reason why smoking is important is because we know it increases the perioperative risk because it paralyzes your cilia, but also in the long term it predicts for lower graft failure as well as decreased survival as well. Gastrointestinal issues. So can you transplant people with Hep B, Hep C? The answer is yes, you can. So you either treat them before, or I guess you can treat them after, bearing in mind things like interferon and things can cause some neuropsychiatric issues. Of course, you'll screen for cirrhosis and HCC and things just to make sure that that is all good. Pancreatitis, you'll screen for. No transplants for 3 months after pancreas. After pancreatitis, some of the medications are associated with it. Cholecystitis. If they've had previous cholecystitis, then you'll just take it out preemptively, because the last thing you want is someone who's sick and you just don't know why that is on the transplant board. If they've had diverticular disease in the past, you just want to make sure that's all quiescent. As you give the immunosuppressants, they're more prone to bowel perforations and I guess microperforations and sepsis that way. Recurrent disease. This is a big issue for our patients. Membranous nephropathy, so that recurs in about 10% of the patients, but it hardly ever causes disease to cause the kidney to fail. Diabetic nephropathy, again, the recurrence is 100% in the patients, but again, it's unlikely to cause the graft to go down. FSGS, so that stands for focal segmental glomerulosclerosis. So there are different types of this, and so the type that we need to watch out for is the autoimmune type. So essentially, the pathophys is they think there's some sort of circulating factor around the body, and then it latches into the kidney and causes the podocytes to disperse and therefore the protein to leak out. The reason for the plex is to just try to get those antibodies out. There have been some interesting case studies where they've put in a transplant into someone with primary FSGS. It causes leak and instant proteinuria. So then what they've done is they've taken out the kidney and given it to someone else, and it's fine in that somebody else. Yeah. So that's exactly. So that's the theory of how they think there's a circulating factor involved. Lupus. So that it recurs in about 25% of biopsied kidneys, but because the medications for immunosuppressants for rejection, which are TAC, mycophenolate, are the same as lupus, you hardly ever get clinical disease. She's got lupus, correct. Anti-GBM disease, do we have anyone with that at all?
Don't think so.
Who's the other plexi people that we got?
No, she was a myasthenic gravis. Haven't got any.
Ah, yeah, right.
Haven't got anyone else at the moment.
Okay, all right. Anyway, autoimmune. This one, primary oxalosis, is essentially about some metabolic defect which makes you get more prone to stones, and so it's a liver kind of defect. So for these people, you might want to consider a liver plus kidney transplant at the same time. And IgA nephropathy, one of the most common causes of GNs for the patients. And so that does come back, but again, it doesn't tend to fail the graft. So most of the time, they're okay. The ones you need to look out for really is the FSGS that you can actually do something about. Infections. Can I transplant my HIV patients? Again, the answer is yes. Yeah. So they're starting to work on this, especially in South Africa. I heard this talk from one of the physicians there a couple of years ago, and they said, look, we just have so little kidneys that if it's a HIV positive donor to patient, then you can transplant it across. What about vaccinations? So the vaccinations for the patients, ideally you want to do it pre-transplant, because when you give the mycophenolate, they just blunts all your response to any vaccinations that you get. But yeah, so you'll get your yearly flu vax for whatever it's worth. Do you know the ones that you need to avoid? So it's the live vaccines, which is the MMR, the polios. Because it's a live vaccine, it will theoretically infect them. Okay. What if the patient has had cancer? So the usual break point is about 2 years. Of course, if it's just in situ cancer like a BCC, SCC, you cut it out, it's done, it's fine, you can go ahead and transplant. Same if it's just like a localized prostate cancer, because, so many people are floating around with that, that's fine. Hematology kind of things. Can you transplant if the patient is anticoagulated? The answer is yes. So this patient who we talked about before, so she was on she was on warfarin because she had a sinus thrombosis. So they just stopped it temporarily and just did some Clexane post-op. And if they've previously had clots, again, you just continue on the anticoagulation. Of course, you can't be operated on if you've got apixaban or clopidogrel, but you can do it if they're on aspirin.
What if they actually have bleeding disorders, like yeah, like that type of stuff?
So haemophilia is okay in the sense that you can replace their factors.
Oh, right, okay.
Yeah.
So is that transplant patients aren't, or transplant waiting list patients aren't put on apixaban as a rule?
Yeah, pretty much. So you want them on warfarin, something that you can reverse. Yeah, because you'd go with a heparin infusion and then you'd transplant. Okay, so we've been through all the organ systems: the brain, the heart, the lungs, the GIT, recurrent disease, infections, cancer, and the hematological stuff. So now that workup just makes sense, right? So you look at their urine, just looking if they've got any sort of weird urine infections. You look at their basic bloods, their lipids, making sure that their bone bloods are in order, their potassium, their phosphate, the calcium, their PTH. You'll do their typing, so their HLA matching, which is separate to your ABO blood typing. You look for any infections that they've had in the past, including things like TB, Hep B, Hep C, HIV, all these other weird random viruses that Mel made me write up a pass slip for. You'll just make sure that their cancer screening is up to date. So this is just really an age-appropriate one. So, urine cytologies are a plus or minus, mammograms are plus minus, but definitely, your pap smears, your bowel cancers. You'll do a cardiovascular thing, at least with an ECG, and then depending on their age / their risk factors, moving on to their MIBIs and their echoes. With their imaging, you'll do at least the chest x-ray again, just looking for gross cancers which are hanging around, but also looking at their vessels, because as we discussed, you want to plug that kidney into the arteries and make sure that it's okay. We've talked about the transplant kind of process. We've talked about what patients need to go through to get to that. We've talked about both the acute phase with the massive fluid shifts, putting up with all the medication burden as well as their side effects, and also the long-term consequences as well: cardiovascular risk, their bone health, infections, rejection, and cancers. And so the take-home points, as we discussed, is that transplants offer a high quality as well as quantity of life, but it has to be targeted to the right patients, as we've kind of just discussed. And second of all, that the patients have to be robust to face all the challenges that they might face. Questions?